For me, all healthcare has to be about maintaining and improving the health of individual Australians. Without that focus on consumers, healthcare can just become a jumble of numbers and statistics, disconnected services and treatment options. If the people who develop health policy and the people who make their livings from delivering health services don't listen to and learn from what the consumer is saying, then they can become lost in meeting the needs of their own services, rather than meeting the needs of health consumers and their communities.
I suspect a long time ago was a consumer disbeliever, but has converted. Emeritus Professor Kerry Golston, who is a gastroenterologist by training and has held various senior roles, both at the University of Sydney and the Faculty of Medicine as Associate Dean, and was heavily involved in a sort of, it's within living memory, but in fact was a very effective process of health reform in metropolitan Sydney. It was called, was it GMCT squared or GMT squared? And essentially this was a process trying to rationalise health services and make them more focused on the needs of consumers in Greater Metropolitan Sydney, and develop some very important principles about healthcare, the right care at the right time by the appropriately qualified health professional. And in fact succeeded in many respects in terms of reform, despite a lot of clinician blood on the floor. Could you please welcome Kerry Golston?
Thank you. Thank you, Norman, and thank you for asking me here today. This is really a personal account of how I changed my views, as Norman said, from when I first became involved in pushing healthcare reform in New South Wales. I'll touch on some aspects of being involved in this reform over the last 12 years. It's still evolving, not only in New South Wales but throughout Australia, and involving consumers in a bottom-up approach help change clinicians' attitudes from competing against each other, working in silos, to working together, looking at the needs of a population as a whole, because clinicians by and large are programmed to achieve and to compete, hospital against hospital, department against department. So this was about a journey starting nearly 12 years ago, where we worked out we had to care about populations and working out the priorities we needed for reform in Greater Metropolitan Sydney. And what I'm going to describe to you is that in this journey, not only did hospital specialists welcome nurses and allied health professionals as equals, but they finished up welcoming consumers as equally. And this contributed mightily to the reform process and changed the attitudes of me and others from scepticism to enthusiasm about consumer involvement. Principles. The principles that have driven this reform from the beginning were decided very early on and became a sort of mantra. Firstly, that, as I said, planning should be population-based and not related to individual hospitals or fiefdoms. Now, I've got a very clear recollection of a very early meeting where someone from the back row, who happened to be a consumer, said, listen, you guys, you're all specialists, but do you know that Prince Alfred Hospital, St Vincent's Hospital, North Shore Hospital are in the centre of Sydney? And where has the population of Sydney moved to? It's now out west. And he said, for 27 years I've been living in Emu Plains, which is way out west of Sydney. And he said, the question I put to you is, why should my neighbour have to travel 3 times a week, an hour and a half's drive each time, 3 times a week for renal dialysis across Sydney? Why can't these services be closer to her? And he mentioned this time and time again. So eventually these specialists from the inner city, who actually lived close to these hospitals also, came to realise there had to be a change. Had to be a change. The second principle was that equity of access was paramount, and that goes hand in hand with the first one. And for example, the cardiac network, very early on, decided, because the population had changed, that there had to be new cardiac catheter centres started at Wollongong, Gosford and Nepean to save patients travelling with acute heart attacks to the centre of Sydney. And finally, the other principle was that acceptance, that change had to be driven by both clinicians and consumers. And this bottom-up approach of clinicians and consumers working together was written up in an article in The Lancet, which was entitled "Towards the Health System, turning the health system 90 degrees down under." And what did we find consumers achieved? Firstly, we found they added a unique perspective, keeping the clinicians reality-based, keeping them reality-based. Secondly, they ensured that meetings always focused on the care of the patient and clinicians did not go off on their favourite tangent. Thirdly, constantly, it was observed that they brought fresh ideas to each meeting they attended. They did not inhibit clinician discussion, but they certainly helped make discussions very robust and were not afraid to interrupt the flow of clinicians' talk. Many brought with them extra skills that were invaluable. For example, I remember the consumer on the Burns network had been a Burns patient, but he's also a psychologist, and his analysis of the interaction of the clinicians on that network was fascinating. And finally, consumers were great advocates, we found, not just to the health department, to the minister, but also the media, in a way clinicians who worked in the system could not do.
There are many issues in relation to consumers that we're going to talk about over the next 2 days. Karen Carey has a lot of experience over many years. She was a predecessor to Anne Mackenzie as chair of the Health Consumers Council of Western Australia, has sat on many national committees governing at a Commonwealth level, setting policy, particularly in the cardiac area and service improvement, and now sits on the board of the Consumers Health Forum. Please welcome Karen Carey.
Hi everybody, thanks for coming along today and thank you for giving me the opportunity to speak. The first thing that I was asked to speak about is the consumer journey, and I know that we hear these terms all the time, but what does it actually practically mean? There are a few things, I think, characteristics of what makes up a good consumer advocate, and I think that they are generally things that are in common. In the first instance, usually you'll find somebody who has been harmed by the system. Either they've been harmed or they've had a family member harmed. And those representatives are willing to loan their story to the consumer movement in order to effect change. And I think that there needs to be respect around how important that role is. But I also think it needs to be acknowledged and then move on. I think a really important thing is that people realise that their experience wasn't unique. And so in my own experience, I had heart valve surgery that went wrong. I've had 3 open heart surgeries and 3 strokes, infarct of kidney and spleen. So I had a really bad time. But the thing that made me a consumer advocate was realising that the thing that went wrong in the first instance could be happening to other people, and that if I didn't do something, then it would continue to happen again and again. And I think that's a really important stage in becoming a consumer advocate, is that you go beyond your own personal experience and start to work on the system. my experience in sitting on expert committees with lots of clinicians is that quite often the conversation, the discussion goes off to really fine clinical points that are not really appropriate to what's being discussed. And having the consumer advocate there can help to bring them back on point. And that is, this is about improving healthcare systems and about improving health outcomes, bring it all back on point. And I think that's an important role. And, you know, sometimes I think we're able to do that just by sitting at the table. Because once you're sitting at the table, everyone else has to look at you. And when they start to move away from the consumer issues, they have to face up to you and put their priorities first. So I think that sometimes it's just valuable to be sitting there. Creating loops is about making sure that there's feedback in the system so that we're not just going into one direction, not testing whether or not what we've done is right, not testing whether or not it works, not testing whether or not it changes the consumer experience on the ground. So we need to have those loops built in. I think the healthcare environment has changed. A decade or so ago, we had the attitude that if something was effective in healthcare, it would be funded and we would have access to it. And that has really changed. What we now know is that we have a limited bucket of money, and that for every new thing that we bring in, we have to take something out. And so I think that we haven't had that discussion about rationing at a community level. I don't think people realise that there's been that change. And therefore, we haven't had the discussion about what we value. So when you go to a rationing system, and I am fully supportive of a rationing system, I think that you have to have limits on the money that's spent. But when you go to a rationing system, you need to make sure that what you are putting forward as your priorities are the priorities that the community would want funded. And I don't think there's been that discussion. And I think that, again, in this type of organisation, there is the opportunity to have that discussion and test out some of the decisions that are being made about rationing. Also, similarly, the issues around cost effectiveness. I think that we have very rapidly moved to using certain formulas for determining cost effectiveness that I'm not sure that the community would actually support. And I think that this is an opportunity to be having those discussions.
Over the last 5 years, I think, there's been a shift in some of the dialogue, and that dialogue has been about patient-centred care or consumer-centred care or, you know, family-centred care. There's 100 little titles that have been given to this shift. But it actually says it's not just about engaging consumers or having them involved in whatever part of your being that you're doing. It's actually about measuring what their experience is and what their outcome is. Has a greater focus on us actually thinking about what is important for patients or consumers and how we can really understand the impact that our service delivery system has on them and what we can do to improve that.
Are they annoying consumers?
No. So most of our consumers, I have to say, who sit on committees
Do you want to get out of here alive today, Jason?
Most of our consumers are ex-complainants who have had a bad experience in our system, and the thing that we do most is bring them in and say, tell us how to fix it. And in doing that, they sometimes say what we don't want to hear, but when it's right, we listen. And most of the time it's right.
Expectations must be pretty high.
Yeah, they are.
And
they keep us honest.
You'd be sitting there going, I've got no chance of meeting that expectation. Or you're just an extreme optimist.
No. I actually find that the consumers understand the system better and actually manage their expectations before I have to manage their expectations. So they understand the constraints we're working on. We tell them all of the constraints that we're working within, but we still find ways to work around that. I actually think they come up with better solutions than we would if we were just thinking about this alone.
If we want a healthier society and healthier communities, we must engage with consumers at every level, as individuals and active partners in their own care and in planning and improving better health policy and services. Talk to the people in your community, the people who use and pay for health services. They can tell you what works and what doesn't, and from my experience, they want to help make a difference.